First, when lawsuits were announced suing Medicare Advantage companies, two in particular, UnitedHealthcare and Humana, and maybe other ones to come, for the use of artificial intelligence in automatically and routinely denying care on Medicare Advantage. Well, now, CMS, that's the Center for Medicare and Medicaid Services, these are the people who run Medicare, have now given their opinion in a final rule on how and when you can use artificial intelligence. And it's pretty shocking to me. We're going to talk about that. And then the MedPAC leader. And what is MedPAC? It's a nonprofit organization of industry leaders from different organizations, mostly nonprofits, doctors and people who know finance very well, talking to Congress about how Medicare is doing. They report to Congress on the strength of Medicare and make policy suggestions to Congress. You'll be shocked at this interview. My friend Cheryl Clark, an awesome reporter on health policy, she did an interview with the head of MedPAC. You'll be shocked to hear in his own words, and then other doctors reacting to what he had to say about Medicare and Medicare Advantage. Then the Advantage plans are at the time of the year when they're facing their new financing for next year. They're being told that it's going to be cut next year, the money for Medicare Advantage, by less than 1%. And so here come the lobbyists, and you'll hear about the crying. We'll talk about it. Drug price negotiations. It's all over the news. Fantastic. The Biden administration, Biden-Harris administration, has now initiated drug price negotiations for the top 10 most expensive drugs out there. How and who is it going to impact and when is the detail that you're not hearing in the news. And then a Texas hospital goes off on Medicare Advantage. See what they put out on social media and why you might need to pay attention to it. So first, let's talk about this. CMS issues guidance for artificial intelligence, and they say algorithms and artificial intelligence powered software tools. Now remember, this is a computer deciding whether or not you get coverage, or if you're left the hospital and you're in a skilled nursing facility, still recovering, artificial intelligence, which is the nature of those lawsuits, has been deciding when you're going to get out of the hospital based on the criteria that the computer thinks you should be doing. So now CMS says artificial intelligence can be used to support Medicare Advantage plans. Remember, we're going to talk about the distinction in just a minute between Medicare and Medicare Advantage. They are distinctly separate. Medicare Advantage is not all Medicare. It's separate, it's private, it's different. And Medicare Advantage is where they have the restrictions on your care. It's where they have prior authorizations, denials of care, having to do appeals and all that. That's not in original Medicare, which is a massive option that people are not being told about. I'll cover that in just a few minutes. So on Medicare Advantage, now CMS says, yeah, it's okay, you can use artificial intelligence, but the payers, that's Medicare Advantage, are still bound by CMS internal benefit requirements and non-discrimination rules under the ACA. That's the only part where they talked about discrimination. The agency said in a guidance to insurers. I want to read to you just part of this article. It says, quote, this is the article talking about this. And if you want to see all these articles and all the documentation, it's linked in the description of the video when the live is over. Quote, we are concerned that algorithms and many new artificial intelligence technologies can exacerbate discrimination and bias. Well, so are we. The agency wrote in a February 6th memo, Medicare Advantage organizations, which they try to nicely say MA. What is MA? It's Medicare Advantage. It's the private Medicare, not real Medicare. Medicare Advantage organizations should, prior to implementing an algorithm or software tool, ensure that the tool is not perpetuating and exacerbating existing bias or introducing new biases. It's all about equity and inclusion and that stuff. But what about people who are dying when they can't get care? That's more important than just, are you being racially discriminated? Are you dead or are you alive? That's the part that I'm concerned with. The guidance comes as scrutiny of payers' use of artificial intelligence increased in 2023. UnitedHealthcare, Humana, and Cigna are facing lawsuits alleging that they used artificial intelligence tools or algorithms to wrongly deny care to Medicare Advantage members. Key takeaways from the article: because of how rapidly software technologies are evolving and overlapping definitions, CMS has now clarified its perspective on the difference between algorithms and artificial intelligence. Algorithms can imply a decisional flow chart. Artificial intelligence is a machine system that can make predictions, recommendations, and decisions. Number two, there's a big crash outside our window. Always happens this time of night. Number two, payers can use algorithms to support coverage decisions, but it is their responsibility to ensure that an algorithm or AI-based tool is compliant with the agency's coverage decision requirements. Well, if it was, probably wouldn't be these massive lawsuits that are seeking class action. For example, Medicare Advantage carriers must base coverage decisions on an individual member's medical history. Problem, that's not what they're doing. And therein lies the problem. It's not based on you, it's based on what a computer thinks you would be doing based on your age, your demographics, and your CPT codes, why you were diagnosed in the first place. So the carriers must base these decisions on your medical history, physician recommendation, or clinical notes. The problem that doctors were saying, and you can see it in the previous video where we talked about the announcement that AI has been used in the lawsuits that were announced, they're not listening to the doctors. That's the problem. The doctors know the patient. They're treating the patient. Then a computer back at the Medicare Advantage place says, oh no, your age and your gender and everything, you should be out of that skilled nursing facility in 2 days. That's all you're good for. Get out. Should be based on physician recommendations and clinical notes, not on a larger data set. Well, that'd be nice. Number 3, 4 takeaways. Algorithms can be used only to help predict the length of stay for post-acute services and not as the basis for terminating coverage. This is what we want to see implemented. Terminating coverage can be determined only by first re-examining a member prior to the termination notice. Well, that'd be great if they start doing that and looking at them as an individual. For inpatient admissions, algorithms and artificial intelligence alone cannot be used as sole reason to deny admission or downgrade to an observation stay. This will be great if they actually do this. We'll see. Number 4, Medicare Advantage organizations may deny coverage for basic benefits only for reasons such as another Medicare Advantage exclusive, network limitations. If you got a network limitation, you can't go within the confines of the network. Yep, they're going to deny you care. Or non-compliance with their prior authorization rules. Another exclusive of Medicare Advantage. Welcome to the free plan that you signed up for. You got a free plan and a free tube of toothpaste, but you just can't get in the hospital or in an acute care facility afterwards. Algorithms should be used only to ensure compliance with internal coverage criteria. That sounds great. AI cannot be used to shift coverage criteria over time, constantly shifting. One of the big problems named in the lawsuit is this is restrictive criteria that's not made public and nobody knows what the heck it is. The doctors can't even find out. How did you arrive at that decision? Well, that's proprietary. We can't tell you. And every company is different. AI cannot be used, according to this new rule, to shift coverage criteria over time, and predictive algorithms cannot apply internal coverage criteria that are not made public. Well, hallelujah. Bring the kids home. Let's see if that's going to work. But for now, yeah, you can continue to use an artificial intelligence. You just have to say on the back end that a human was actually involved in that denial. This was a slide from the earlier announcement. This was in December, where we've covered it first. The second of the lawsuits. Very interesting. If you're on Medicare Advantage, you should see how they're making these coverage decisions for you. And remember, the alternative is original Medicare, possibly with a Medicare supplement or Medigap plan where there are no restrictions. We'll talk about that again in a minute. This is fascinating. This is the article where it was covered on MedPage Today, an awesome read that I read every time it comes out. A friend of mine, Cheryl, which I've helped her on a couple of stories, Cheryl Clark, she interviewed the head of MedPAC, who advises Congress. And I want you to hear his very interesting take. This will take just a few minutes, but if you'll do like I do, grab a cup of Joe. You might want to pause it right where it is. Even in the live stream, you can pause it, come right back to it. You can play it over again. If you think I talked too fast, you can hit that little wheel button and slow me down. But this is fascinating, and you should hear how the people who are making Medicare policy and Medicare Advantage policy recommendations to CMS, what they think about Medicare Advantage and the future of Medicare Advantage. Let's see.
Interview with the head of the agency that advises Congress about Medicare policy. One of the most well-read pieces on our site last week was an interview Cheryl Clark did with Michael Chernow. Chernow is a Harvard professor who chairs the Medicare Payment Advisory Commission. Because Medicare Advantage enrollment has been growing so rapidly in recent years and serious problems about it are emerging, Cheryl wanted to know if traditional Medicare will still be an option or whether we'll all have to be on Medicare Advantage at some point in the future. Cheryl is here to tell us more. So, Cheryl, what is the difference between Medicare Advantage and Medicare? Why is there a concern that Medicare might go away?
Well, Traditional Medicare covers doctor visits, hospitalization, imaging, labs, and other services, and allows you to see any provider who takes Medicare anywhere in the country, but not prescription drugs. Medicare Advantage plans are run by private companies that receive a capitated sum each month to bundle services, including drugs, and they throw in other services that Medicare doesn't cover, like vision and hearing. And Medicare Advantage plans now cover a majority of beneficiaries, which is a huge jump from years ago. So the idea behind MA is sound. You get coordinated care from providers who talk with each other. The patient is less likely to receive low-value, potentially harmful care. And these MA plans are great for healthy people, but there's a catch. And a lot of people don't understand this. MA plans require patients to just use their provider networks, often called a narrow network, and that can mean long wait times. They often do not include specialization centers for conditions like cancer. And many of these plans use AI-generated algorithms to deny coverage.
You know, it makes sense that some people would be drawn to Medicare Advantage plans only to find out later the hard way that the plan doesn't actually cover all of their needs.
Exactly. Many people I know didn't even know they were in an MA plan. They enrolled when they were healthy, often persuaded by brokers who, as it turns out, get high commissions for enrolling beneficiaries into these plans. Now, as they get older, they realize they never read the fine print, that there are hundreds of dollars of hospitalization copays, that the drugs they need aren't in the formulary, or they'll have to pay out of pocket for a specialist. Plus, some MA plans have been defrauding the Medicare Trust Fund, claiming their enrollees are much sicker than they really are in order to generate higher Medicare payments to increase their profits. In fact, this year, MA plans are expected to receive $88 billion more than Medicare would have spent if patients had been in traditional Medicare. 𝗏 told me that MA covers 90% of beneficiaries in parts of the country even now. So I asked him if every beneficiary would eventually have no choice but Medicare Advantage, and what should policymakers do to fix these problems.
What did he say?
Well, he didn't answer some of these questions directly. He said the traditional Medicare will be available for the foreseeable future, but he didn't really say what that was. More importantly, he said repeatedly that Medicare Advantage plans deliver better care than traditional Medicare, something a growing number of patients and doctors disagree with vehemently. He acknowledged the need for Medicare to address these concerns about whether the plans are working as they should. One solution might be to cut MA plan rates, he said. But he held fast to the idea that patients should know they are making a trade-off when they enroll, and I'm not sure they always do.
We got a lot of interesting responses to your piece. What were you hearing from doctors and other healthcare professionals?
Almost universally, they were extremely critical of 𝗏's responses, saying he dodged the questions. As providers, they wouldn't enroll in an MA plan, ever. Here's a sample. Having practiced medicine in Iowa as a pulmonologist for the past 29 years and planning on retiring in a year, I in no way would consider an MA plan. I am daily curtailed in my ability to care for my patients. Several noted that 𝗏 didn't know what kind of a plan his own father had, suggesting that he, as one commenter noted, doesn't get it at all.
Thank you so much, Cheryl.
Thank you, Rachel.
Kind of interesting that the doctor said they wouldn't be caught dead on a Medicare Advantage plan. Just another factor. I mean, if you're considering which type of Medicare you're going to go with, original Medicare with a Medicare supplement, where you can absolutely go to any doctor in any hospital in the country that accepts Medicare, which is most everybody, and no restrictions, no prior authorizations, no referrals, no network restrictions, no denials of care from artificial intelligence. Or you can do Medicare Advantage and have a free plan and take what they give you and have a different plan every single year because they change dramatically, sometimes in the middle of the year. You know, I wasn't going to mention this, but I'm going to tell you what happened today. Today, I did an interview on a Zoom call with an oncologist in a Midwestern state, let's just say, and he was so fired up about one particular insurance company. I've mentioned the name today, but I'm not going to single them out right here, about how much they're denying care for his patients. And he is so fed up. He's going to go public. He's getting a lawyer, and he wants everybody to know to stay away from this insurance company. And we're trying to find a solution for his patients where they can change their insurance company. And on Medicare Advantage, I just informed him of the different enrollment periods. And they've got this Medicare Advantage open enrollment period until March 31st, but time is really running out, where you can change Medicare Advantage plans for one last time for the duration of the year. But anyway, fascinating story. Hopefully I can bring some of that to you in the future. If you hear from a cancer doctor who treats people with cancer and he said, man, I wish everybody could be on a Medicare supplement. I'm like, yeah, from your lips to God's ears, except that many seniors can't afford a Medicare supplement, or so they say, until it's literally life or death. Hey, I want to thank you if you've been a subscriber of our YouTube channel. If you want to follow what's going on with Medicare, and a lot of things are breaking in the news, things are going to be changing soon, and I've got much more to cover here. But we hit 100,000 subscribers last night while I was sleeping. I woke up and I'm like, whoa, look at that, 100,000 subscribers. So I have one of those cool silver YouTube play buttons. I just want to thank you if you've been along for the ride all the way up to this point. It's not about the video, it's about the people that we can help, and we've helped a lot. This is the start of the negotiations with CMS. And that's where the Medicare Advantage companies are all say, hey, we can't afford anything anymore because the costs are going up for giving out care. And what they're saying right now that's unique is during COVID, they made record profits. I mean, hundreds of billions of dollars on Medicare Advantage. Why? Because the government did not stop to pay them a certain capitated amount. That's the same amount every month, every member, for all the people on Medicare Advantage. And yet during that time, you stayed home. People weren't getting routine screenings. They weren't having elective surgeries. They weren't having all the things that they would normally do if they were not under lockdown. Well, guess what? Lockdowns have been released. People are going back, and people are getting things done that they needed to have done earlier so they can remain healthy. The Advantage companies are not liking it. In fact, they were expecting the CMS announcement to go through the roof, with reimbursements to be higher for next year. Always higher, right? Medical cost inflation justifies higher rates. When the Biden administration came back and said, whoa, 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 we're going to be at less than 1%, but it's going to be a downgrade instead of an upgrade on your money, they started going a little bit nuts. So they're all putting out this information that things are going to be gloom and doom. And what are they going to do? And I don't know if we can just stay in business. We're going to have to cut off benefits to people, reduce benefits next year on Medicare Advantage. It's all going to be gloom and doom. What this actually is the march of the lobbyists. This is the first salvo in the negotiation round and round that it goes with CMS. And I'm sure as we get closer to election time, I'm not talking politics, I'm talking healthcare policy. This is what's influencing healthcare policy. So before you say, you're a Democrat, you're a Republican, whatever, I don't care. What I'm telling you is this is how healthcare policy is determined. As we get closer to an election, they're going to suddenly reverse themselves and say, see what I did for you, seniors? And here it comes.
May scale back Medicare Advantage benefits if the Centers for Medicare and Medicaid Services carries out a rate cut next year, executives said Tuesday. The health insurance company is the latest to report higher than expected costs for its Medicare Advantage members and to bemoan a CMS proposed rule that would trim benchmark payments by 0.16% in 2025, excluding the effects of risk adjustment. That wouldn't be enough to cover expenses, CEO Sarah London said during a call with investor analysts to announce fourth quarter and full year earnings. We're in the position of not trying to grow MA. We're ultimately trying to recover margin in the back half of the decade, Centene Chief Financial Officer Drew Asher said. Our product may be a little less attractive for seniors if we don't make progress on rates. Medicare Advantage carriers, including industry leaders, United Healthcare and Humana, are sounding an alarm about surprisingly high medical expenses in the closing months of 2023 and a negative benchmark update, and may react by hiking premiums, trimming benefits, reducing provider reimbursements, and reconsidering geographic expansions. Although CMS has proposed a modest rate decrease, Medicare Advantage insurers are still adapting to numerous policy shifts in recent years that have squeezed their margins, such as the creation of a new risk adjustment methodology and stricter quality standards under the Star Ratings program. Combined with the ongoing implementation of those and other policies, the 2025 Medicare Advantage proposed rule would reduce payments by a net 1.3%, according to Centene. That wouldn't be enough to make up for higher costs, London said. Bearing in mind the continued expectation for the multi-year phase-in of risk adjustment changes, we view the preliminary rates as insufficient with respect to general medical cost trend expectations, London said. Centene's stronger-than-expected exchange performance has led the company to upgrade annual revenue projections by $2.5 billion to $134.5 billion. $137.5 billion. The company expects at least $6.70 in adjusted earnings per share in 2024.
Wait, we're making all this money? we're making all the money, but we want it to go up. $600 billion. Golly Moses. That's a lot. Find out what the CEOs are being paid. So here come the lobbyists. They're marching up and down K Street right now, going down to Capitol Hill saying, how can you do this to seniors? It's an election year. Don't you want to get reelected? Don't you want people to come out for your party? You better increase the funding for Medicare Advantage and stay out of our way. Matter of fact, we just talked about YouTube here just for a minute. And like I said, this is not about me. So let me show you what they're doing. These are the Medicare Advantage lobby. They posted a video the other day. It was 6 days old and it still had, how many? No views on it whatsoever. Bless her heart. Somebody's got to help them with the marketing over there. I'm available. 0 views in 6 days. And let's see what that video is and see how good it is at advocating for Medicare Advantage. I'm curious. I want to see it. Oh, it's powered by who? 𝗲𝗃, Association for Health Insurance Plans. That's the Medicare Advantage lobby. Let's see what it says about them. Get me out of there. Hello. 𝗲𝗃 is the national association whose members provide healthcare coverage, services, and solutions to market-based solutions and public-private partnership, making healthcare better. That sounds great. Let's see. Whoops.
Seniors in rural areas still need high-quality care. Having Medicare Advantage.
There we go. Don't play it.
Seniors in rural areas still need high-quality care. Having Medicare Advantage helps me make sure that I'm doing everything I can to stay as healthy and strong and flexible as possible.
You're welcome for being the one person that watched that video, and I hope it was not too expensive to produce. But anyway,
seniors in rural.
Beautiful. So it's in the news that the Biden-Harris administration has gone out and passed the law, the Income Reduction Act. No, it's not what Inflation Reduction Act. Right. Part of it is they're going to negotiate. Finally, Medicare is going to negotiate with the drug companies to bring down the price of the most expensive drugs. Now, this sounds great, and we're going to see how it actually is implemented. But here to share with you what's going on with this.
In some consumer news now for you this afternoon, Medicare has started its first ever negotiations with drug makers over the cost of 10 expensive medications. Those negotiations come as Senator Bernie Sanders is once again taking the pharmaceutical industry to task. He issued a report highlighting the cost of 3 drugs that are far pricier here in the U.S. than they are in other countries. Among them, the list price of Bristol-Myers Squibb's Eliquis. That's a blood thinner that reduces the risk of stroke. It comes in at $7,100 here in the U.S., but it's just under $1,000 in Japan, Canada, Germany, and the UK. Big difference there. The CEOs of several major drug makers are expected to testify at a congressional hearing about these kinds of things this coming Thursday.
Very, very interesting. So what does that mean about these drugs? What's the timeline on it? This is 2024. It just started 2024. What are we going to do about this? Oh, just like everything else, you're going to have to wait a couple more years before you get absolutely any benefit to this whatsoever. From their own slides, here's what's happening. So in last year, 2023, they started these negotiations, getting ready to figure out what drugs they're going to be negotiating on. And then they're going to publish at the last quarter of 2024 what the fair prices would be. Fair is a word that's not allowed to be used in my family, in the household, because there's no such thing as fair. Fair to who? But anyway, that's what they're going to do. And then they're going to go after the companies hardcore, take their profits if they don't go along with the negotiations. So this could potentially be good. But again, not until 2026. Who's going to be here between now and then to keep you up to date and informed on whether all this gets thrown out and changed? That'll be me. Watch this. This is amazing. This was a comment posted on my YouTube channel. And this person said, this was just last week, I was just in Van Horn, Texas. Van Horn is a small town in West Texas. There's a small hospital there. In the local weekly paper, I saw an ad advising local seniors that it was not too late to return to original Medicare and get out of Medicare Advantage plans. This is further evidence to me that the articles I have read about Medicare Advantage hurting small hospitals probably saw here, that's why he's commenting here, and causing their closure. After all that I've read and seen, Medicare Advantage should be shut down. So I did some research and I found the hospital, and then I found the publication. Then I found their social media, and this is the hospital, Culberson Hospital. These are some of the things that they posted, and this is unredacted. And I wanted you to see what the hospital administration is telling seniors about Medicare Advantage. This is not Christopher Westfall. It's just my research showing you what hospitals are saying. If you currently have Medicare Advantage, quote unquote, Advantage plan, can I turn on the thing here so I can show you there? That replaced your Medicare coverage. But remember, it is replacing the Medicare that you earned and paid for your entire working life. So if you have a Medicare Advantage plan that replaced your Medicare plan, because you can't have both, it's one or the other. If you're paying zero premium for your Medicare insurance, guess what? You're on a Medicare Advantage plan. You don't have original Medicare for that year. Back to the article, Chris. It's possible you have lost coverage with your favorite medical providers and services, exclamation point. Please check with your provider to see if their services are covered with your new plan. The good news is you can still switch back to original Medicare. The Medicare Advantage open enrollment period is January 1 to March 31. To change back to a more complete coverage, you can call 1-800-MEDICARE to unenroll from Medicare Advantage and then confirm your enrollment into Medicare. Let me caution you right here. Yes, it is that simple. During this period of time from January 1 to March 31, for clarity purposes, let me explain, you can go back to original Medicare. But if you do that on your own, it's just as dumb as performing surgery on your own brain while you're awake. Why? Because if you leave Medicare Advantage and you don't replace that supplemental insurance with a Medicare supplement plan, then you're going to be screwed. What does that mean? That's a technical term, by the way. That's not filthy. It means that you're going to be liable then. Yes, you got the freedom to go anywhere, any hospital, any doctor, anywhere, you can go anywhere. However, you've got to do it and pay 20% of all the outpatient costs yourself. All the cost, 20%, you have to pay yourself if you're on just original Medicare. You pay a big fat Part A deductible if you walk into any hospital, which you're free to go to any of them that you want to. But without a Medicare supplement that pays that other 20%, that pays that massive deductible to go into the hospital, you're in bad shape. My recommendation is to contact an independent insurance broker to explain to you and show you Medicare supplement options. If you cannot pass the underwriting, if underwriting was required, don't pull the trigger and go back to original Medicare. There's a right way to do it and there's a wrong way to do it. On our website, we talk about exactly how to do that, and I'll show you that in a minute. This is another one. This is an opinion article from Concord, New Hampshire. This is the hospital in Texas posting this. The author clearly explains why Medicare Advantage is not ideal coverage for our older population. In a nutshell, Medicare Advantage is not Medicare. It replaces your Medicare coverage with a plan that is run by for-profit insurance company and will give you less choice of medical providers and services and require pre-approval for services that your provider deem necessary or deny services altogether. Bam! That is the truth that I've been trying to tell people. Here's another one, and I'll just zoom in here. This is what it looks like. Traditional Medicare with a Medicare supplement. This is what we specialize in. That's anything you want to do. And then Medicare Advantage. What's that little thing down there? Oh, they're not the same? No, they're not the same. Let me zoom in. Are you looking at a menu of healthcare options? Understand what you are ordering. This is the hospital saying this. Medicare Advantage limits your choice of medical providers and requires pre-approval for many treatments your provider deemed necessary. Advantage plans replace your Medicare coverage with plans managed by for-profit health insurance company. When you are sick or need medical attention, Advantage plans can also have surprise out-of-pocket expenses, such as high deductibles or copays. Traditional, original Medicare, when paired with a Medicare supplement, gives greater choice. You choose your medical provider, and your provider has the flexibility to provide the medical care they think is best for you. You be the judge. This is your brain. It's your brain on drugs. Nancy Reagan, circa 1982. Thank you. That's amazing. And here's the zoom in on that graphic, which is fascinating. And I'll just end with this one. Another story about insurance companies that sell Medicare Advantage plans. They are making money at the expense of elderly Americans. Advantage plans replace your traditional Medicare plans with a plan that costs you more when you need it the most. And they cite this article from Yahoo Finance that says, by denying claims, Medicare Advantage plans hurt rural hospitals. We've covered that already. It goes on and on and on. And I want you to know there's a difference. There's original Medicare and a supplement that you can get to go with it, and we can help with that. Our service is free. It doesn't cost you a dime. Or you can do Medicare Advantage. And neither one is right for everybody, but if you had your choice, if you had an unlimited budget and paying $100, $150, or $200 a month for the best healthcare choices that are possible, if you prioritize that and you've saved for that in retirement, is probably a better bet than the massive amount of barrage that you're going to get signed up with one of those free plans, because we as agents make a lot more money if I put you on a free Medicare Advantage plan. It's just a fact. Don't have one without cancer insurance. Don't have one without a hospital indemnity plan. And if you do have a Medicare Advantage plan and you want one of those, we can help you with that, because there's a big gaping hole with cancer treatment. If you go to our website, seniorssavingsnetwork.org, there's a green button there. If you're trying to go from Medicare Advantage back to a Medicare supplement, you have to watch how to do it. And I go through it step by step, precept upon precept, how you do it, and you don't want to do it the wrong way, and we can help you do it for free. This is a video for Medicare explaining what I just said. This is from Medicare.gov. If you don't believe me, this is the government's own site explaining this very process.
What's the difference between original Medicare and Medicare Advantage? When you're getting started with Medicare, and during certain other times of the year, you can choose which way to get your health coverage. There are two main ways: original Medicare and Medicare Advantage. Each option offers ways to get your Medicare health benefits. You can choose the option that fits your needs. Original Medicare includes Medicare Part A and Part B. This covers certain medical services and supplies in hospitals, doctor's offices, and other healthcare facilities. You can choose any hospital or doctor that takes Medicare anywhere in the U.S. In original Medicare, you'll pay a deductible, an amount you pay before Medicare starts to pay. Once you meet that amount, you pay a co-insurance or co-payment for each covered service. To help lower your share of the costs, you can buy a Medicare supplement insurance policy called Medigap. Medigap policies are sold by private companies and help pay some of the remaining costs for covered services and supplies. If you want prescription drug coverage, also called Part D, you can join a separate Medicare drug plan. Part D helps cover many drugs, and each plan can vary in cost and specific drugs covered. Next, let's take a closer look at Medicare Advantage, also called Part C. Medicare Advantage is an alternative to original Medicare. To join a Medicare Advantage plan, you must have both Part A and Part B. You'll pay a monthly plan premium in addition to your monthly Part B premium. With a Medicare Advantage plan, you join a private plan that bundles Part A, Part B, and usually Part D drug coverage. In most cases, you'll need to use doctors who are in the plan's network. In Medicare Advantage plans, your out-of-pocket costs vary. Plans have a yearly limit on what you pay out of pocket for Part A and Part B covered services. Once you reach your plan's limit, you pay nothing for Part A and Part B covered services for the rest of the year. Most Medicare Advantage plans may offer some extra benefits that original Medicare doesn't cover, like vision, hearing, and dental services.
Whether you're considering original Medicare or Medicare Advantage, it's important to understand your coverage options and compare choices so you get the coverage that's right for you.
Ready to learn more about your Medicare coverage options? Visit Medicare.gov and select Get Started, or review the Medicare and You Handbook for more information. This product was produced at U.S. taxpayer expense.
Pretty interesting, huh? They said basically the same thing that I said, except one little caveat. Let me just clarify. They said that when you hit your max out of pocket on Medicare Advantage, you don't have to pay anything else. Okay, that's not true. Here's how it works in the real world. When you hit your max out of pocket on Medicare Advantage, you do have to pay if you continue to go outside of their coverage area. You go to networks that are not approved by them. You go to a doctor or specialist, cancer hospital, Mayo Clinic, for instance, Johns Hopkins. You're going to go to the best treatment in the country. And you say, wait, I reached my max out of pocket, so I should be able to go, right? Because I reached my max out of pocket. It's like my deductible. No, sir. The only thing that goes toward your max out of pocket and protects you are those services that are prior authorized and approved, and you do it exactly the way that they say to do it, which will be the cheapest possible route to achieve that result first. Very often we hear that they want to do a CAT scan or an MRI. But then the Medicare plan, Medicare Advantage plan will say, nope, let's start with a very simple x-ray. Let's see how that does for us. Meanwhile, our patient friends are writhing in pain, wishing they could get the determination of what the real problem is, and then start toward the prior authorization to get that surgery or corrective action to get that thing fixed. No, your max out of pocket does not do one thing for you if your procedure is not approved by the plan. Just important that you have that in clarity, since we do help with both types of plans. My name's Christopher Westphal. Been doing this for 27 years now. Gosh, we're in another year already. We're here to help you. Our service is free. And that's all my story. And I'm going to keep telling the truth and keep telling people what's going on with Medicare, and keep telling my agent friends that you've got to tell both sides of the story, because most agents simply don't. The reality is it's a lot easier if you're in sales to sell something that's free, to give away a benefit that's a government benefit that's free. However, one might think there's got to be more to the story. And if you look at the tens of thousands of comments across our YouTube channel over the last 10 years, you'll see countless stories of people telling their stories. Read them. They're very, very interesting. Not just me saying it. I live vicariously through the tens of thousands of people we've helped and talked to. And some people, unfortunately, which is the worst part of everything, some people we can't help because they made the wrong decision and they can no longer get onto a different plan, because after a while, you can't get on a Medicare supplement anymore if you can't go through underwriting. We specialize in that. We can help you through that process, but sometimes, often, we have to give bad news that you're just simply stuck. So we try to make the best out of a bad decision, bad situation, and try to get somebody on the plan that best suits their needs. And that's all we can do. We can't be all things to all people. We can't write everybody that even calls us in. We try to get to everybody. We absolutely can't. We do the best we can. I want to thank you for being a part of what we've been doing here for so long. 100,000 people have had the faith to subscribe and keep up to date with what's going on in Medicare. Over 10 million people have watched our videos over the years, which is just crazy to think about. Well, we'll be here continuing to help you at no charge whatsoever. If we can help, reach out. Otherwise, we'll see you on the next video. Thanks for being here.